first surgery with anchor fixation of a recurrent dislocation. The anchors cause a complete damage to the shoulder joint, to the glenohumeral joint, so that a second surgery was done to remove the anchors, but he got a complete destruction of both the head and the glenoid. He had continuous pain and marked limitation of motion, so that the only option was to do prosthesis to help him get rid from this problem. So we planned the prosthesis using the PSI. All the measurements were done with the 3D, and information we got that it is a glenoid component of 46, and the width of the shaft is 7 millimeter, and the humeral head which is 46 millimeter, and the height is 18. So the PSI component for both the glenoid and the humeral head was planned and ready to use. Now, when we did the surgery, we were faced with several problems. The first problem was that the shaft, instead of being 7 millimeter, it was 13. It's about double the measurement we got. And the company who brought the prosthesis, they told us that they have all the sizes, which is up to 15 millimeters. So frankly, they had only 9 millimeters and 11 millimeters. So we used the one with 11 millimeters. The second problem was the head height. They didn't have the correct height of the head, which was used, and we had to use a head which make a stability of the joint. And we had the information also from the planning that the head has a size of 18. This is a problem because they measure it on a head which has an erosion, the affected head. So it is smaller than the actual head. Usually we ask for them to measure the normal side, so we have the size of the normal head on the opposite side in order to use it. This was not done, because to get a good result we have to have the size of the head which matches also the tendons and muscles which have the length of a certain size of the head. Now, the head width was correct and the glenoid size was also correct. So we had many thoughts and we said, okay, we have to have a good information to plan the prosthesis. This is very important. We have to do first a planning, and we have to have the information for this planning. This information we have got, we have to get it from the company. Also, we will suggest here some improvement in the PSI component of the glenoid and the head to ease the implantation of the prosthesis. Now, the planning, according to the information, we have to have 12 data. 7 of them about the head and shaft, and 5 about the glenoid. I will go through each one quickly. First, we have to know the head height and the width. The width is usually the same as the normal side, doesn't change, but the height will change in the affected side because of erosion of the osteoarthritis. We have the retroversion angle of the head. This is usually not measured. This is very important also, but by using the PSI component based on measurement from the biceps sulcus, this gives us approximately the correct retroversion angle. Now we have to know the valgus angle of the head and measure that with the prosthesis we use, and we see to compare it with the valgus angle of the prosthesis, so it has to be matched. If they are not matched, we have to consider that in the implantation. The offset of the shaft, which is the center of the shaft to the center of the head, has also to be measured in order to place the passing head to the prosthesis. We have what's so-called the anatomical head, which can give us the possibility to use the correct offset. Now, also the shaft width, which is very important. This has been measured between the two cortical bones, and it is better to measure it using the X-ray or the CT. The length and width of the glenoid usually are measured correctly, and they are also have the same with the PSI component. Now, another important, which is for me it's a very important point, I would consider also to use the so-called cancellous bags. These are a cancellous bone inside the glenoid, and by removing the cancellous bone and putting a cement, we can have a very good fixation of the glenoid component. Also, the version of the angle is important, but it is usually the same. Only in cases of instability, either anterior or posterior, we have erosion of the glenoid rim, either anterior or posterior, which has considered in the surgery. This is a very important point, which is called the glenohumeral offset. Actually, this, considering that and reconstructing this offset, or this will give us the good result of motion of the shoulder. So we have the angle of the lever, the center. The center is between the head and the glenoid, and then the space between them. So we have to have the bone stock getting the same point of the lever arm. So if we have erosion of the head, we can replace it with a normal head by measuring the other opposite side. But if we have erosion of the glenoid, this is usually a difficult surgical procedure to reconstruct the glenoid by using bone stock or so. But we can use also a larger head, but this will be on the cost of motion. Now, this is the component, the PSI component used for glenoid, and the blue points, which is what my suggestion, to use this holes, to make holes to remove the cancellous bone from the sac and the glenoid. Here we see on the right, this is the component, and suggests 2 points in order to remove the cancellous bone from the backs on the base, in the base of the coracoid and down the scapular neck. Also, I suggest another device in the glenoid component to have the anatomical position to see if there is any, if in case of erosion, to replace that with a bone or consider that in our implantation. Also, the length of the glenoid can also be considered in the component. Now, this is a PSI glenoid component. It is put on the shaft and on the humeral head. we need to have the axis of the guide. This is very important. As you said, in this case, the axis of the shaft was displaced, so we have to have the central axis of the shaft in order to put the shaft in the correct position, not in valgus or varus. So I suggest also to have the component having device inside it like this metal, or of course from the PSI to have to localize the center of the shaft. Now, in summary, we have to do a good planning of the surgery with all these informations. I suggest the modification or improvement of the components, PSI components, and it is very important to have these informations and bring the company with their prostheses and all sizes and make a planning before surgery. This will help very much and will ease the surgery and make it quicker. Thank you very much.